Good day. My name is Rudy Page, Making Connections Work, and welcome to Practice Self-Care for Life. And this dialogue is around Self-Care Week. So Self-Care Week is the annual national event that raises awareness of what we can all do to improve our physical health and mental well-being. This year, the theme is Practice Self-Care for Life. So I'm really pleased. Our two guests today are Kye Gbangbola, Chair of the Sickle Cell Society, and Patrick Ojeer, who is a NIHR Improvement Leadership Fellow. Good day, both.
Hi.
Great to see you. And thank you for being part of this dialogue this morning, which will also be rebroadcast on Fresh FM Radio London, and you can pick that up on www.freshfmradiolondon.com. Kye, I would like to start with you first. Please provide us with an overview of how Sickle Cell Society supports patients and service users.
Okay, firstly, thank you very much for inviting me today. And the Sickle Cell Society is an organisation that's 40 years old. So it's one of this country's longest serving Black organisations. And we are a charitable organisation, specifically as a patient organisation award-winning through the King's Fund and GlaxoSmithKline. And what we do is provide services, as you've said, Rudy. So those services are specifically in the areas of training and education. So we work across all of the areas of healthcare. And of course, we play on the main pitch, which is amongst all of our people living with sickle cell, who are known as sickle cell warriors, because of their huge resilience. Maybe I'll touch upon that later. We also are involved in various things like lobbying. So you would have seen the media recently talking about the inquiry, the sickle cell inquiry. It was a parliamentary inquiry, and it is No One's Listening is the title of the document, available from the Sickle Cell Society's website. And I can give you that link later. We also do lobbying, as I've just outlined, screening programs. So all newborn babies, no matter what their ethnicity, are screened for sickle cell, because white babies do have sickle cell. And we have a holiday for children that we've had since 1988. I love that, one of my favorite parts. We also have Give Blood, Spread Love. And that's about blood donation and research into cures. So cures are coming along for sickle cell. We have a helpline to help people that need our help. And there's plenty of people that need our help, from experts, clinicians, even when we're talking about guidance on coronavirus. And we at the Sickle Cell Society enabled the clinically extremely vulnerable people to be able to be listed with sickle cell and be protected. And we have, of course, advocacy. And in some ways, that could be part of what we're doing today in terms of self-care for life. So I hope that gives you a good overview of the Sickle Cell Society and the services that we provide.
Excellent. Thank you. And I will come back to you on a couple of points that you made earlier on. So Patrick, we know you've had a personal and professional interest in sickle cell, and you've got a long track record. So can you describe your role as an NIHR Improvement Leadership Fellow?
Well, I must say good day to you. Thank you for having me again, Rudy. If I may say, this fellowship, this is a National Institute of Health Research education program to develop leaders in innovation and improvement. That's one of the main things it does, but also the advanced change in healthcare organizations and beyond. It's also to translate evidence into practice for population health. This is a really interesting program. It's open to all people into healthcare and allied organizations. And through a year-long program, I found the most interesting part of that program was overseas visit. We spent some time overseas, and our visit was into Massachusetts, Boston, in which we had spent some time in the Institute of Healthcare Improvements, IHI, and also two of the leading hospitals in Boston, speaking and sharing information and knowledge with senior management and staff. And that really gave us a lot more practical knowledge to see how improvements are being made and conducted, and what sort of tools, systems, and are used in gaining improvement.
Okay, thanks for that. That, in a sense, brings me back to Kye around the system collaboration and how it might work. So Kye, you touched on the relationship with the clinicians and some of the decision makers within the system, which, as we both know, are really important. Can you kind of outline how the Sickle Cell Society works with clinicians and the decision makers within the system itself, and how aligned are they with the mission and vision and the necessary improvements in terms of the quality of care for sickle cell patients? And of course, you indicated the most recent report.
Absolutely. So the if you imagine a pitch, there's various sides of the pitch, but there's the side that you've just described, where we need to work with policymakers and the various organizations that exist within the health services. And this is an area that we deem as the main area of advocacy, but there's the other major half, which relates to real people, the sickle cell warriors, their families and carers. So what we seek to do is bring all of these, unify all these pieces into the one place. And this is essentially what equality is about. So the main issue that's been identified in No One's Listening, the all-party parliamentary group Sickle Cell Inquiry, which took place this year, and had people from all over the country provide information. And when I say all over the country, it's not just people living with sickle cell, but we had clinicians. It was amazing. You know, clinicians coming together, consultants, top consultants, saying, do you know what? These issues are down to inequality, structural inequality. You know, when you are in a forum where people are given permission to just tell the truth, you know, and policymakers just tell the truth, what are the reasons behind the issues we face? So when we start looking at these issues of inequality, and we're working with these organizations, and these organizations are myriad, you know, from NHS to NHS Race and Health Observatory. We also work with organizations that approve drugs, NIHR, the European Medical Agency, NICE, NIHR, and we're doing all these pieces of research. It's all about integrating these pieces to get the overall story. And the overall story that we've now gathered, that the MPs are solidly behind us on and are showing their commitment, because it's okay us giving out our commitments, but it's about this broader pitch of people pushing in order to bring about the change that enables us to have a fairer health system. So the health system as it exists is made up of numerous policies and strategies created by people of the past. Now we are people. So as people, we can change that. It's just about changing those policies and practices so that there's a fairer society or an organization working within society. So when we look at these issues of equality, they are the things that cause disparity. If you have a fairer society, then equity falls into place, access falls into place. And then these other things to create that are discussed within No One's Listening. And so No One's Listening as a title came about because I said, you know, the one thing you can do for a person that has had a condition that they're expert in because they've had it for their whole life is just to listen. It costs nothing. You know, it shouldn't be the case that people are withheld from having treatment because no one wants to listen to their care plan. No one wants to listen to the letter of a doctor, of a specialist, for whatever reason of a person's immutable characteristics. That's wrong, okay? So we have to change that so that people can have whatever tools that are necessary, go into hospital, get the care that they need, and continue with as much quality in their life. And how do you do that? That is about representation. If you are listened to, that's part of representation. If you're part of the decision making, that's representation. And the NHS will often talk about no decision about me without me. Involve people so that they understand the issues and we remove ourselves from some of these fatalities and bad practices. Also education, especially of our experts. So we're looking at the medical councils and the nurses and midwifery councils and the England Medical Council. These people have no training on their curriculum. The basis of that is you can talk to nurses. We did a study that went into Parliament. 80% of people in medicine have less than an hour's training on sickle cell disorder, which is the country's fastest growing genetic condition, affecting well over 15,000 people. So we need to get education right. We also need to get funding right. We need to get research right. Because when we talk about access to treatment, sickle cell has 5 treatments, whereas a condition known as cystic fibrosis has 511 treatments, okay? And there's a third less, so there's 10,500 people with cystic fibrosis. But remember this, everybody, this is never about pulling anyone down. What this is about is improving services and saying, what about us? And in that manner, we work together to understand the issues, and we pull in our politicians as key advocates, and then we continue to push for change so that we overcome these systemic issues and we overcome all these integrated aspects, and we're involved.
Excellent. And it sounds very much like the report itself is can be a great catalyst for a much wider stakeholder model that relates to a program of activities where there can be some system intervention, particularly at this time where the NHS is going through a transformation, as you know, the integrated care system, and then the much more work being done at the neighbourhood level, at the borough level, you know, place where the people are, and obviously public health are an integral part of this story as well. Yes, I'd be interested in your thoughts around the role of public health, given the nature of public health, and again, its impact through the local authorities on, you know, individuals, you know, that are under their care.
So we as an organisation, the Sickle Cell Society, punch well above our weight. we're not a large organisation, but we work very hard. So with Public Health England, we have a great relationship with senior people like Professor Kevin Fenton. We have a great relationship with the Department of Health and Social Care, and we have a great relationship with chief medical officers. It's absolutely necessary, because it's in the development of these relationships that we can come to understand what issues are there, and we can work together to seek to overcome them. So it is just essential at this point in history, where we know what's happened over the past year. We know the importance of Black lives, that we push forward to bring about changes, working with and bringing people in as fantastic allies. And we will see what will happen into the future.
Excellent. Just before I come to you, Patrick, again, the commissioning intent, and you know that there's always challenges around the commissioning. So how detailed have the commissioners now been in terms of understanding that kind of environment that sickle cell patients live in, and the kind of support that they need from the commissioning of the services, in your experience? Sorry, Kye, that's to you.
To me or Patrick?
You. All right.
Yeah, I can take it.
Either. So, all right. To you.
The issues of commissioning are very important, because one of the things that I made in the article that went out in the Guardian yesterday was there are standards of care, and when people die and coroners do their various reports like prevention of future deaths, and those reports identify for our loved ones that it was preventable as a death due to a lack of basic care, or worse, because there are also issues of neglect. And these are attributed, as we found in the report No One's Listening, to issues of inequality and race. These should have consequences for people. And those consequences are about accountability within those organizations. So when commissioning says, if you have sickle cell disorder, it is a medical emergency, not unlike a stroke or a heart attack. And these are what has been positioned in order to care for people that arrive at A&E that are on your wards with sickle cell disorder. Then we should have a right to expect that level of care. And what is identified is that if sickle cell is about excruciating pain, likened to being repeatedly hammered, and many women with it will describe childbirth as far easier, preferable to a sickle cell crisis. So when we arrive at A&E, it's 30 minutes door to needle. That is the commissioning standard. And when you monitor the various specialists across the country for sickle cell disorder, known as hemoglobinopathy coordination centres, and there's 10 of them across the country, and they work as a mini network in themselves. So they radiate out advice to other nearby hospitals. But when you arrive there as a sickle cell patient, a person living with sickle cell, and you don't receive your pain relief, what that causes is the occlusions, the blood clots caused by the sticky sickle cells in capillaries, that causes things to get worse. It escalates. So it's so important that we meet these commissioning requirements, and we set all this out in documents like this. 300 pages. So there's no excuse. Essential intelligence for all clinicians and people providing care to people with sickle cell disorder. We set that out. Now, this can happen repeatedly. I can give you many examples of where it's happened to me. It happens repeatedly to a patient that is unwell. So what we do together is explain to the hospitals, this isn't working for us. Things have to change. we've got the data, we've got the statistics, we've put the complaints in, which are necessary as well. So how about we work together and present ourselves with standards that are commissioned standards that work? And this is, again, that piece that just falls out due to issues of inequality and people just not listening. And it's amazing that the causes of the causes always boil down to issues of race and inequality for our people. And it's not just in sickle cell, it's across the wider piece. So if we're going to stay healthy and not come across the issues of the Black Report in 1980 that stated there's inequalities, there's disparity, and the gap between the health of Black people and their white counterparts is growing. The same in the Aitchison report, the same in the Marmot report, 2010, and now Marmot's done a 2020 report. It's still growing. So there's a lot of work to do. You know, that you read the report and its recommendations, there's a lot of work to do, seriously.
Yeah, and no doubt there'll be a 2022 report and a 2025 report. But
we want those reports to be better, Rudy, don't we?
Absolutely, absolutely.
We with all data, as we all know, we are where we are. So what it is about progression. And within the system, there needs to be that accountability. And I think that's the road that you're heading down. And I'm hoping, not hoping, but more of us will be involved with that journey that you're making to support that work around the system, because it's really is important.
It's essential.
Yep, absolutely.
So Patrick,
shine a spotlight on things, and that should enable wider eyes and oversight, because oversight is sorely missing. You know, you shouldn't be able to harm people and have this all over the press, all over the world, you know, and have all these stigmas, which is another subject. Back to you, Rudy, sorry.
And you raise another point as it relates to that. So when the CQC examinations now, how historically has sickle services to sickle cell users, have they actually ended up in the final report of the CQC? Given now we're at a place where, when it comes to at least the workforce race equality standard, the RES, that there's an indication under the well-led element within CQC reports. So what I'm asking then, as it relates to CQC reports in terms of patient feedback, friends and family tests, where does sickle cell even mentioned in those particular reports? Because those reports are about public confidence, service and service quality.
So as you would have understood from the previous discussion, sickle cell has kind of been low down the priority. And what is happening is it is elevating, it's rising up the priority. And reports like came out this week from the MPs and Parliament, all the support, are ensuring that rise. So within the CQC, previously, they wouldn't have touched the recent deaths that have happened. Now they are immersed in it. They are going to the hospitals where these events happened, and they are doing full reports. So the expectation is that things are changing. They will be in the res, and the interests of people living with Sickle Cell Society, the interests of those providing care for people living with sickle cell will be pushed to the fore. And then our job is to stop it slipping back.
Sustain it. Absolutely. Absolutely. So, I agree with that.
So Patrick, if you want to follow up on something that Kyes said there, which I can see, has sparked you, and then I'll come to the question I had for you.
Well, I could only agree with what Kye he's articulated very well, because this is one of the many things that Kye and I worked for many, many years, you know, is to get sickle cell up the ladder of priorities. Okay. I mean, I remember really when I really started getting involved in this service improvement, I remember having a word in Brent with what's asked the chief commissioner, main commissioner, what is the priority of sickle cell service? And he said, oh, wow, it's beyond low and low. It wasn't a priority at all as far as he's concerned. So how can you try to influence them to bring about change? And that was in Brent, right? Which is, again, had a very good sickle cell service in Central Middlesex Hospital under Sally Davis at the time, right? And still, the commissioner didn't have any priorities whatsoever. Now it's getting up there, is to sustain it and to keep pushing on. Forget about slipping it back. It really needs to be pushed on.
Service need will ensure it's sustained.
Well,
remember, we're going forward. We're looking forward now. So service need and the reports and the focus on the improvement that we're talking about will ensure that we go forward.
Look, we've been doing that for long enough.
That may be so, Patrick. That may be so, but
we have to get people like yourself.
In order to get public confidence,
yeah,
those of us who are in a position press forward, and demonstrate. Here's the evidence, and we keep pressing forward. We've got to look forward, because we are where we are. Just like we say with the data, we get the data, and it's about progression. How we got here. We're here. We are where we are. So it's pressing forward, and people such as yourselves are very much, at the forefront of communicating to those of us who can assist as well, because we need to understand. So public understanding is important.
Absolutely.
Okay, thank you for bringing me in at this point. I would totally agree. I think we always have to understand our history. We have to understand where we've come from. So one of the important things about this report from the MPs is that this is nothing new to people living with sickle cell disorder. We've experienced it for decades. So the American civil rights movement was highly predicated on sickle cell, to the point where President Nixon in 1972 brought in an anti-discrimination law that enabled research into sickle cell. And that's why America advanced somewhat more rapidly than we have in the UK. So we always reflect back on, the history, because we learn from that where we need to progress going forward. And we are here right now, and the position that we are in is not a fair one. And so from this particular base, we have to enlist the support of any of the more powerful decision makers. And those powerful decision makers are essentially secretaries of state in particular areas that impact us, including the Department of Works and Pensions, in the main organizations that commission care. And that is increasingly subject to the ascension of the laws, going to be the integrated care systems as well. So we're already developing our relationships in those areas in advance. It's necessary in order to have a sustainable health service for people living with sickle cell disorder.
Absolutely. And of course, the first line in the NHS Constitution says the NHS belongs to all
everyone.
People.
Yeah.
Right. Now, there's another important aspect to this around research. So both of you, is that what are the areas of research that really need to be done? And what research is actually really going on at the moment when it comes to sickle cell? And then there's another third point to that, which I've heard on other platforms, is that there's always a challenge when it relates to research, particularly if it's focused around African and Caribbean population groups. It tends not to get funded. that may be the case, but I'd be interested to know what are the areas of research that are needed. There's the medical stuff, but also there's obviously what goes on, which you touched on, Kye. There's the social stuff as well, you know, the economic impact that it has, the impact on children's education, and what does that then mean for their future. So I'd be interested in that. Let's start with the research before we go into the policy area.
So there's of course the social economic side. The mission of the Sickle Cell Society is to ensure people have their full measure, people living with sickle cell enjoy their full measure socially and economically. And, you know, these are the things of life in many ways. Research, the idea is that we have a cure that enables organizations no longer to exist because we're in a position to be able to simply monitor the good quality health that people experience. And there was a lovely program called Race Around the World, and a young woman on it had stem cell therapy, and she, from having sickle cell, where it's debilitating, very limiting, prohibitive of one's life, enjoyed a completely normal life, to the point that she could do everything and anything. That's what we want for people, of course it is. So research at this time relates to if we can get a cure, but there's also these life issues, and these life issues revolve around the fact that many people that come from Black communities with Black heritage don't have the same start as some other people. And we talk about those issues of, if you're living with sickle cell, there's a psychological impact, there's burdens, and those burdens travel through life. They travel through life from the need for medication, the need for care, the way in which we work as employees within organizations, the way in which social services interact with us. There's all these different areas. Now, I know Patrick's wants to come in, so you go, Patrick.
No, I just agree with what you say, because the research is essential, and that area really, like other areas, is lacking. Okay, for many years now, they've been on the grapevine, the research on stem cell transplantation, take for example. There's fully matched, which is the best possible deal of sibling match, but that's not really feasible because there's not enough. And there's been research on half match donors, but this has been going around for some time now. It's yet to find any sort of positive results from that.
But why, Patrick, can I just ask you that though? You touched on those other areas of research. So isn't that just means more work needs to be done, and if more resources went into that area of research, then in the long run, the same way that we get our vaccines, you know, when money and expertise and the scientists get behind it. So what I want to understand, what are the areas of research that in the end resources and advocacy should get behind? Kye.
So sickle cell is the result of a highly successful gene mutation. And that gene mutation enabled people a degree of protection from malaria. So you bring that into the modern context, and it's like our COVID-19 vaccinations enable us to be able to have a degree of protection, but it's not an absolute cure. Right. Now, on the 3rd of March 2017, there was a story about gene and cell therapy, one injection, one cure. Yeah. So for sickle cell, that is exactly what happened. There's also a type of research called CRISPR. Again, one injection, a complete cure. The nature of the cure is no more sickle cell. Right. Without the destruction of a person that is needed with stem cell transplantation, because of all of the paraphernalia that goes before it. So there's cures that are coming, okay, and they should be here within the next couple of years. and we're already to an extent in phase 3 trials for some of them. And that means that the next stage is making it available. But the issue in terms of equality is still extant, in that there are gene therapies that are curing rare diseases already.
Right.
So it's a case of try and ensure, and what we are ensuring, and where you're right, Rudy, where people need to get behind is that let's push for sickle cell to be at the forefront of that. And we are virtually there, but the sustained pressure will ensure that people will begin to receive those treatments. Yes, they're expensive, but of course, given the stats that I gave you, there is a priority that sickle cell disorder needs that. And when you consider the situation with HIV, and HIV 25 years ago was likely to kill people, and now there's prophylactics, there's injections that were talked about in the same paper that we discussed earlier, The Guardian, yesterday. One injection, nobody needs to know that anyone even has it. People even forget that they have it. This is how we're moving in medicine. There's excellence in medicine. We have to remind everybody, there is excellence. All we are saying is, what about us?
Yeah. So having said that though, what I really want us to focus on, because remember, the context of this is self-care. This is self-care week. So what I'm really getting at is, what is our role and how can we improve the role ourselves? And you've touched on this, the communication, right, amongst ourselves in our own communities, our own platforms. But first of all, we need to understand. So that's my point, and pushing you both. What are the key areas of research which you just outlined? You know, where are the great benefits going to be for that? But the community needs to understand. As a public, let alone the people who work in the system, but more importantly, if the community understand, then they can be great advocates and push the decision makers and those who are accountable and those who are responsible for making decisions. So so I'd like to spend a few moments. Let's talk about the gap within our own community. We're not blaming anybody. So what I'd like us to just have a dialogue in the next few minutes about how we can improve ourselves, our own involvement in understanding, because part of the stigma, as we know, and we've had that in mental health service as well, and obviously there's a mental health impact as well on sickle cell warriors. But so what can we do for ourselves? Now, we all know that in order to get the best outcomes for individuals, they needed to be treated with love, compassion, and with humanity. We accept that. So it's what is it then? Would you want us, our own community, to understand about sickle cell?
I mean,
and how we can support those two elements? It's about us. Yeah.
Could I start this? I'm sure Kye gonna come in.
Yeah.
You see, the thing is, first of all, to understand, we ourselves got to understand a lot more about the sickle cell disorder, how it affects our own. We got to able to manage our own in the community and at home, and those things you could do by following the basic examples of understanding disease by be hydrated all the time, fully hydrated all the time, so therefore you always have lots of liquids.
Right, so you're now talking about the
individual, but also
individual who has sickle cell.
But also expand, because when you start to understand yourself, you could also get engaged with the GP for example, ensure that they know and have this sort of clinical standards of care. So that would help again, go further understanding, because most of them will be having a sort of specialist nurse working in the outpatient department. Communicate with them, help them, and let them help yourself to live best you can without having a crisis. And then the bigger stuff is what the organizations and people like Kye, myself, and you would be able to bring about a change. But in the meantime, let's look after ourselves in a basic way so that we are prepared.
So I would agree totally. You see, the history was 1910. Walter Knoll was the first person whose cells were identified to have sickle cell. And when they spoke to the scientists said, "Oh, Walter's a black person, that he's not important." So understand, we were denied a lot of knowledge. So that's why your point is so important, Rudy. It's not about blaming anybody, and it's certainly not about blaming people within African Caribbean heritage communities. And we move forward, and there's so many examples of that, from Tuskegee to Henrietta Lacks, and Henrietta Lacks's immortal cells have been responsible for virtually almost every cure, and our understanding of the nature of human beings in space travel. So everything in medicine has been off of the backs of Black people. So when we start moving forward, to answer your question in terms of how do we engage with society, engaging with society is about understanding some of the stigmas that we've been forced to endure, such as, people with sickle cell, they're just drug addicts, they're seekers. And there's a chap called Wally Smith, who's the top professor in sickle cell in America, and he simply says any medical person I ever hear say that is an opiophobe, and their types are not wanted in the industry because they're not helping, they're not showing love, they're not showing care, as you said, for a patient. They're not trying to help, they're just trying to stigmatize them. That's unacceptable in medicine. Remember your point about it should be care for all at the point of need. So when we move this on in terms of talking about us, there's a bit of catch up that needs to be done. But I often say, you medical people and others, people in the healthcare industry, you like to tell us what to do, but we're experts in our own right. So involve us and we will speak for ourselves. And then we will come to a comprehensive position that works for us into the future. So we will have, as a society, the Sickle Cell Society in this case, we constantly have that dialogue with people. We call them patient education days. And we have several in a year. And we transfer all the emerging knowledge through these patient education days, bringing in the people that have done the research to have the conversations, and then you can do the Q&As as is appropriate, and people can decide for themselves. It's all about choice, you see. At the end of the day, people just need to have these choices. Do you want it? Do you not want it? Or do you want these other things? So we continue to work with people on the ground, people living with sickle cell disorder, their families, their carers, and healthcare, so that all people are in the same position in terms of their understanding. All people are in the same position in order to develop knowledge together. All people are in the same position to be able to provide the right type of care. And that's for children as well as adults, and sickle cell is highly known to affect people in different ways. So there's all this ongoing learning, and that includes with sickle cell trait, as I said, a highly successful gene mutation, but it still involves that mutation that enables cells to polymerize when there's a lack of oxygen. Polymerizing just simply means the cells go sickle-shaped and rigid.
Yeah.
So you will find some people with sickle cell trait that talk about tiredness and talk about feeling unwell. There's a lot of research. We mustn't leave people behind. This is about how we can go forward, taking everybody together, leaving nobody behind. And that's what leveling up is all about.
Excellent. And to raise another related topic to this, and I'm saying this on the basis of just going back very quickly, I like the 3 key points that you made, which is similar to what we're now running as we go through the pandemic as it relates to community wellness dialogues. And that's about the community being informed, reassured, so that they can make the choice. And you set that very clearly. And bringing in the work that we're currently doing as it relates to prostate health now, we're talking very much on the back of the work with Frank Chiniwundu around screening and the fact that screening, the case for screening as it relates to prostate health is going to be made in a very strong way over this next 2 or 3 years or so on that agenda, in terms of the support for people like Frank and all the others who are doing that work as clinicians. So as it relates to sickle cell and screening, could you talk about that? What happens now, and what would you like to see? What are you recommending to policymakers around?
So I know Frank very well. He's a good friend, Frank Chiniwundu.
Yeah.
And screening as regards sickle cell is something that we've done since 2006. Indeed, we pioneer, and people come to us from around the world. In fact, I've got calls coming in at this very time about how other countries can do screening well. Now, screening well is that we have a program where 6 weeks into a pregnancy, we can assist families to have knowledge that will advise them and they can utilize to guide them through the rest of the pregnancy. Every baby, as I said earlier, of all ethnicities, all babies born in the UK are screened for sickle cell disorder, and you will receive a letter if you either display your baby has sickle cell trait or sickle cell disorder, and that is followed up by a person, because it's essential to have a degree of counselling and understanding. Yeah. So these are the main facets behind screening. First, you have to get people aware, bring them into the picture so they're in a position to be assessed, tested, investigated, and support them through. So as a program, we're completely with that. In terms of prostate cancer, of course, if there is a section of the population that is impacted greater than other sections, then they should be screened in order to go about preventative medicine, because it's only on the basis of having a diagnosis that people can receive treatment and therefore go on to receive productive lives. Prostate cancer is a very easy and quick way of harming people, especially Black men. And it's a needless way to have a demise. So I concur with everything you said, Rudy, and I will give Frank all support.
Excellent.
Absolutely.
Patrick, you wanted to come in?
Yes, I agree with Kye. I mean, screening has done wonders for the sickle cell community. And not only that, this ongoing sort of program they have, and the support they have, you know, it's for the nurses. I mean, that been really led for a long time by those in Central Middlesex Hospital. I think, you know, it's one of the positives by a long way to help people with sickle cell disease, able to really from the young age able to deal with it best they can.
Yeah, thanks for that, Patrick.
I'll add one thing,
Yeah.
Rudy. Screening is cheap as chips.
Yeah.
So most governments can do it quite easily if they want to be able to plan out the healthcare for their population, because the first job of all governments is to protect society and the public. So it's cheap as chips. It's just pathology. It's not expensive pathology either, and it is allied, of course, to tests, genetic tests. So it's a win-win. In other words, when I say genetic tests, screening of adults to see what their genotype is. So it's a complete win-win for any population.
I agree. And to be fully supported, especially by our community, fully supported, or to have an equally a good system as it is for sickle cell, with support in place.
So, Patrick, Kye touched on earlier on about the sickle cell service specialist centres. Could you just tell us, from your perspective, a bit more about those centres?
Well, he touched on many things, but one of the things he touched really, which is I will highlight, is education. You see, I mean, we got these 10 specialist centres throughout the country.
Right.
Okay. But not only 10 centres out, but we got an overarching body on top, which is the National Multidisciplinary Centre. And they're really to ensure that all these 10 centres maintain the same very high standards. Okay. And really, this is one of the new things that in development, and hopefully it will produce good results in time. But the purpose of these centers really is they are responsible for leadership and education.
Okay.
Right.
And that's within the system.
Within a network arrangement. Each have a geographic area. Each center will have a geographic area. But although there's one center in each geographic area, they may have more than one specialist hospital. Right. And one of the things really, and it's for these specialist center especially to support hospital throughout this area with less expert in sickle cell disorder. So really to support them and educate them with the knowledge, which is great, to bring them up to scratch, because their hospital will just a very few sickle cell patients and they complain.
Yeah,
so
that's good. That's a good point there, because that's again on the basis that if you're a particular hospital, you might not have a high number of people
absolutely
requiring that particular service, but there's somewhere for them to go and get the support.
But the thing is for the clinicians to get that support, first of all, because they have a direct communication with the specialist center. So therefore they're supporting, and they don't have the services that the specialist centers may have. So therefore they're easily to be able to signpost it to that within the area, the specialist center. Okay, that's what happened. And to show that patients can expect the same high quality of care, right? And new measures to measures to see whether it works well for patients. So therefore, that is what basically the HCC is all about.
It's about consistency.
It's about consistency, but not only for one network, it's throughout, because you got this overarching header. Overarching thing, and all the centers then have a regular meeting, and any sort of similar like this new drug that came on to be, because it's only licensed for 3 years. I'm sure now the National Multidisciplinary Center will ensure this sort of drug is administered throughout the country, so that they again maintain that sort of single sort of high quality of care for sickle cell disease. So that is what the HCC really basically is all about.
Let me just come to Kye on that. So Kye, could you tell us a bit more about that drug? A few weeks ago, it got a lot of headlines in the news, and was almost presented as a wonder drug to the sickle cell community.
The new treatment is called crizanlizumab. And if you go to the Sickle Cell Society's website, which is www.sicklecellsociety.org, you will see a nice crib sheet for people that want to obtain that medicine, and they can take that to their doctors, and doctors receive the same kind of crib sheet. Now, this treatment reduces hospitalizations by 50% and 40%, and crises. First, you would say it reduces the number of crises by 50%, and that should mean that the number of hospitalizations is reduced by that 40, it's actually 40%, by 40%. Now, a person with sickle cell disorder, if you were to say to them, I can remove some 40% of your crisis, up to 40% of your crisis, they're going to say, yes, please, because any one of these sickle cell crises can kill them. They can come into a situation where it causes extreme harm. And a sickle cell crisis has a cumulative impact on the bones, the tissue, the joints, and organs. And it causes other conditions like necrosis, which is needing the replacement of hip or shoulder joints and other joints. So it's very important to have a treatment that will reduce the number of incidents for sickle cell. Above other conditions, this has that cumulative impact. So it's important. So that's the significance of this new treatment. And it's an infusion. So it's like you would have when you have a blood transfusion, but the impact is considered to be greater. And if it works and the data flows through, because if you can't measure it, you can't manage it. If you can't manage it, you can't change it to get improvements for the future. If the data works out well, then of course you, I, Patrick, we and the rest of the community will be in a position to say, hey, we want this to continue.
Absolutely.
Right?
Absolutely.
Yeah, and that answer brings me neatly to my final question before we have to close. Is that a few days ago I was one of the speakers at the Faculty of Pharmaceutical Medicines conference, and of course there was, again, as usual, the discussion around equality, diversity and inclusion, or lack thereof, in terms of the way decisions are made. So I'd be interested for your perspective on sickle cell and pharma, the relationship, and again, I'd be very interested in your thoughts around that. And again, what should the community understand about that relationship, and particularly the areas of advocacy around sickle cell and pharma.
I'm happy to go unless Patrick wants to say first.
No, carry on, Kye.
Okay, so in terms of bedfellows, the relationship between certain communities, the Black community, and medicine is allied to the relationship with pharma. And so there will be certain concerns that have resulted from that historic relationship. And nevertheless, what we are in a position to understand is through the way in which trials come through phase 1, phase 2, phase 3, and increasingly involve not only the pharma companies, but also the people of various conditions in need of treatment, involving those people, so that there is a greater degree of trust.
Right.
Because a lot of what we are talking about in this particular relationship boils down to trust. And that can end up being a personal view. Do I trust this? Do I not trust that? And we shouldn't malign anybody for their particular view, other than to encourage a position through data and evidence that can show that something is safe. It is consistently safe. The metrics and the data shows that commonly, when used around the world, you will have a good outcome from it. And that essentially is that relationship between a condition and the condition being sickle cell and pharma companies. You know, they're doing their utmost to try and provide things that increase the well-being, increase those issues so that people can self-manage, have a greater quality of life without constant interventions with healthcare services. And they also are needing to understand, in terms of those quality of life issues, the various intersections, because what we haven't discussed today is there is various intersections for individuals in the way in which they come into contact for their need for treatment and care and their interventions and interactions within society at the same time, which is why education of our children is so important, because you can lose a lot of time from school. So things that are provided, like a good example with pharma is prophylaxis for pneumococcal.
Yeah.
And even in America, a developed country, that has reduced deaths from under fives with sickle cell by 2/3. So there's good things. There are certainly good things.
And
if I could add on to that, Rudy, it's really, it's like, we are bedfellows, but it's like in the sickle cell community, we have to keep on building relationships. And the longer the relationships we build, take time to build those relationships, the stronger it gets. And so therefore this trust is reduced. But really, there's no part of the services or the system when it comes to allied sort of healthcare professionals and organization. You know, really, the stronger the relationships. And by doing that, we talk about sickle cell disease, which is probably, there's far more people ignorant about this disease, even within our own to a certain extent. And we gotta stop that. They gotta be educated, and people gotta know more and more about sickle cell disease. And with these organizations and these industries, it's essential to have a long-lasting relationship.
Yeah, and it's important. Again, we go backwards and forwards between the professionals in our community and the service users, which again, this pandemic has actually shown a key element that we came up with. We spoke about the workforce is the community and the community is the workforce.
Yeah.
So again, when we say education, somebody, that is us, have to be responsible for putting together the programs, setting out very clearly what they are, and then communicating it across all the platforms, the responsible platforms in our communities. But that's not going to happen till those of us who are in a position to provide with clarity the steps that we want the community to take. So the call to action, the community has to understand what the call to action is. And that has to come from the professionals and the people who understand. And of course, and that's based on feedback from the lived experience of the community. And that's why this focus on self-care from the professionals and the providers within our community, as well as the response of our community needs. Yes, Kye.
So there are some very key tips. You see, at the Sickle Cell Society, we grow people, and these people are educated people. On the one hand, they understand they will never, ever be defined by their condition, but so they can achieve whatever they want to achieve. But in so doing, there's points around which they require support. Like any people that you come across of any character or personality, you must meet them where they're at. And with sickle cell disorder and growing people through our children's holiday, and we had 56 children from age of 4 with their care, learning how to look after themselves, massive tip, learning how to have a buddy so that as they grow older and go through transition, which is from childhood, there's a period of time where they transfer into adult care, how to negotiate those transitions. And when they're an adult, have a buddy that looks out for them. So when they're ill, writhing in pain, unable to speak, barely conscious, there's always somebody there to look out for them. There's the usual conversations. You know, if you are Black, look out for these things in life, in terms of equality, in terms of the justice system, in terms of policing and things like that. Make people aware of these issues, but also make them aware of their history. So I loved having the conversation. You know, do you know who Armani Reynolds is, and Mansu Musa, and these great people from history, and as we've gone forward, and what sickle cell is all about. And then the third point I just wanted to make that I noted down here is continuous learning.
Absolutely.
And this is what this is all about. You know, when we're talking about self-care for life, it doesn't stay the same. It's continuously changing. And that's what the patient education days are about at the Sickle Cell Society.
All I could say is, you know, Rudy, it's a pleasure being here again with Kye. We don't meet nearly enough, but we've got the same views and same passion. He developed his he's articulating these things so very easily and very clearly. But you know, again, is for him focus of self-learning and develop himself to be a brilliant person, which he is as advocate for sickle cell. I hope, and I know that will never change. So I'm glad to have him on this platform today, and I'm glad to give him all the time to talk if needs be, because the way he said things that I really, and he knows that, feel very passionate too.
No, you've done a very good job, Patrick, in your role. Excellent in terms of just being able to bring Kye onto the platform that you're part of. So I'm pleased. And also, Kye, very much, and I'm thinking with my work with Dr. Sunday Popaola from Imperial College London. For the last 3 or 4 years, we focused on the 21st century skills, learning skills. So collaboration, creativity, communication, critical thinking. And so much of what that you've said, I can see us being able to again link that and integrate that with the current level of working that we're doing in terms of community learning and young people's learning. So why not have a learning stream that just integrates with sickle cell condition and the sickle cell learning into that? Because we're doing it as it relates to environment, we're doing it as it relates to civic participation, and we talk about community economic well-being, we talk about community wellness. So there's no reason why we can't integrate learning of a particular condition, as I said. And I think sickle cell definitely is, we can model it. We can model that and see how that works. So how do we, as a challenge to ourselves, as it relates to self-care, the same way we're thinking about mental well-being, how can we take a condition then like sickle cell and weave that in through our learning so it just becomes part of what we do and understand? And that's for us to do. That's for us to do that.
Thank you.
But before I leave, I want to go back again to pharma slightly, because at that conference a few days ago, there was obviously the trust and confidence that you touched on. There was also about involvement in clinical trials as well. And of course, having a body of people with the lived experience for the development of, you know, future medication. But also, so I'd like you to say a bit more about that in terms of your aspirations, what you would like to see, Sickle Cell Society and that relationship with pharma. But another important area that's come out through this pandemic is that we introduced the community pharmacies as an integral part of providing that as a trusted messenger. So this trusted messenger model that we developed with various medical professionals from our community. And the reason being is the community pharmacist is there in the neighborhood. It is a primary care provider, you know, and these are where people live. So again, I'd be interested in the relationship between the community pharmacists, and we have quite a few around London, at least in terms of from an African and Caribbean background, who are now coming to the fore as it relates to vaccine confidence. But I'm just now thinking we could do a lot more with that part of the NHS workforce, because 96% of the business that they do actually comes through the NHS. So again, that relationship with the community pharmacists are in our neighbourhoods. They have the generational knowledge. They're trusted members of the medical workforce. So if you could just touch on those two items, Kye, would be great.
Yeah. Did you want to go first, Patrick?
No, carry on.
Yeah.
I want to come on at the end with something slightly different, because I want to touch on something with the HCC. But carry on with pharmacy, because this is interesting and very important to get across what this society represents, what you yourself, with your experience, we really need in this relationship.
Now, nationally, this country prides itself on life sciences.
Right.
And there you have a worthy ally to the pride in life sciences, which comes through the research and working with companies that are pharmacy companies, etc. And then that trickles through all aspects of the community, going through, as you've rightly said, community pharmacists. But there's an issue. And that issue is that many people living with sickle cell disorder have a requirement for various treatments, and living in economically disadvantaged circumstances means that there's difficulties obtaining medications. And unlike other conditions that are on a list that automatically receive free medication, we've been lobbying for decades to ensure people living with a lifelong condition like sickle cell should not be disadvantaged through not having access to treatment through inability to pay. So that becomes an issue. So any way in which community pharmacists can assist with that, as we have put in the report, No One's Listening, that would be of great help. And as we move towards ICSs, there should be that understanding that especially in areas of high prevalence, there needs to be some adjustments to policy in that particular area. But I would agree, you know, when we're looking at pharma, and the Sickle Cell Society work with all sorts that I could name. The reason for us working with them is because we want to develop that relationship from inception to completion, and thereafter beyond, in terms of looking at impact on people of the treatments that are being made available. So there's no unintended consequences. So these relationships just are ongoing and continuous, and they need to be collaborative, as you've said, and we need to be in a position to be able to halt or adjust things if things aren't looking win-win, because ultimately that's what we need out of the relationship with pharma. Success is the way forward, and success enables people to live happier lives, and that's why the Sickle Cell Society is here.
Yeah, excellent. Patrick, last point.
Well, the only point I want to raise here, really, is going back to the HCC, because what has happened in the on the HCCs and the network, especially in West London network.
HCC, please.
is hemoglobin coordinating centers. For this, those are the specialist centers, which are there are 10 nationally. I really want to mention this because it's very important going forward. You know, West London Specialist Center, actually, with a conversation they invite me to, actually, I really discussed, and they really took up what I suggested is to have a PPV
patient
group,
public advisory,
a voice group.
Public voice
Group.
Yeah.
But the important thing was two important things. One, it was going to be independent, completely independent, but well supported.
Yeah.
And also, they would again have themselves on the structure of this specialist center. Now, this is the only center that proposed that to NHS England, and they accepted that. Okay, and as being and also, right, when the society heard about it, got full backing from the society on this, and also to open to probably cascade that to most other, if not all the other centers throughout the country. But it's vital because what we have started to do is put the groundwork in place, and to deal with certain issues to ensure that, take for example, there's 3 specialist hospitals in this particular network, and to have conversions of policies, so that therefore they work in unison, right? Number one. And also with any we've got agreement that say that really any adverse incident happens, that the learning from those, we should be able to have a discussion around that, and then we be able to monitor if those learning are being taken up. Now, these are just going forward, it's just starting to develop, but we try to deliver from a good foundation upwards. So it's essential for that to go forward.
All of this is definitely a topic for another meeting. We can go into, we've raised a lot of key points. So I'd like to thank you both very much for being on this platform today. And I'll just remind everybody again, it's Self-Care Week, and the theme is Practice Self-Care for Life. And our focus has been around sickle cell, and really what our community can do for itself, but also to understand the role that the Sickle Cell Society is playing on behalf of the community, but most importantly within the system of the NHS care delivery system itself. And that's really important. So thank you very much, and take care.
Thank you.
Thank you.